Welcome to Quad A Now, where we explore the world of patient safety, the impact of accreditation, and other topics relevant to outpatient healthcare facilities and dental practices. Join us as we explore diverse topics, share success stories, and navigate the challenges that define the pursuit of excellence in patient safety.
Welcome to the Quad A Now podcast. Today, we are honored to have Joan Kelly, a partner at Press Ganey, as our guest. Joan brings more than 25 years of dedication and expertise in consumer experience in the healthcare space. She holds a doctorate degree in education, along with an MBA and a master's in education. Joan's expertise is in value-based care patient experience design work to curate the experience and achieve desired outcomes for patients. She has also advanced innovation across a variety of multinational organizations, including the Dana-Farber Cancer Center, Harvard University, NASA, the Department of Defense, and the Walt Disney Company. Today, Joan will share her knowledge and insights on how to impact the patient experience. Joan, just to begin with, can you provide us with some background on yourself and Press Ganey and really kind of the collection of services that you all offer to small to mid-sized office-based and ambulatory surgery practitioners for those who might be listening who are unfamiliar?
Great. Thank you so much, Tom. Yes, Press Ganey, we actually manage either surveys, communication, connection with about 90% of all healthcare organizations. And what we do is identify what is the experience that patients are having so that the leaders and staff can help improve what that looks like. And that's through surveys, whether it's web-based, or mail surveys, meeting requirements they may have from a regulatory perspective, as well as how they can make things safer and improve their communication.
Okay, so just as a point of clarification, because at least for my staff and surveyors and facilities, within the context of accreditation, when we talk about surveys, we're talking about the on-site inspection process. Inspection is a less friendly word than survey. So the on-site evaluation process is a survey. But from what I understand, your use of the term survey, just so that we're setting the table correctly for the listener, is that Press Ganey is doing really a traditional sort of satisfaction and a feedback survey to collect information from end users and stakeholders. And we're not really talking about the on-site inspection and evaluation process. I just want to make sure that's clear for anyone who might be listening. Is that correct?
That's correct. Good delineation. The survey we think about is how we can know from the patients how their treatment was, what the experience was, and what their satisfaction in their care. Very different than the more in-depth work that you're doing.
Okay, and then before we really get into the meat of it, what is the stakeholder sort of collection that you're working with? Is it strictly patients, or is there a variety of stakeholders that you would be assessing or potentially assessing, depending on the type of project that is designed for a facility, to have both internal, external vendor relationships? I mean, is it patient focused only, or are there options?
There are actually other options. What we typically begin our engagements with are what are the requirements? So if someone is held to regulatory requirement like ambulatory surgery centers, where if you were part of a hospital that you needed to start these patient experience surveys last January, and if you are independent and separate from a hospital, you need to start it this coming January, it fits in the realm of making sure that you are adhering to the patient experience surveys. But on the flip side, one of the things we also help with is how do we make the experience better? And that often means we have to make the staff experience better. And so we do the staff engagement surveys as well to help clients understand how can we improve it for their staff as well as their patients. Again,
before we really get into the nuts and bolts, it sounds to me, there's obviously a regulatory incentive, maybe a combination of carrot and stick for Medicare certified facilities, which I think we'll get to in a little while. but there's also sort of a value additive process that it sounds to me that you're trying to communicate that you would love for even private practitioners to understand, is that this service, this survey really could serve as a strengthening tool for an organization in how they operate and how they engage their patients and their staff to improve and to be kind of on that constant trail of quality assessment, quality improvement, and experience, sort of that journey. So, while there's some regulatory component, sounds like there's also just a market component and sort of a motivated self-interest. Would that be accurate to say?
That's absolutely accurate, Tom. It also includes with someone who may not be regulatory, if they're opening a new practice, understand what is the environment there in terms of what are those in the area want. If you want to grow practice, we can help you identify what are the dynamics that you need to think about, what might your competitors be doing in that market, and how can you grow separate and distinct from any regulatory patient experience survey you might have. So we help with identifying what are the areas most important, the voice of the patient, how do you make sure you're meeting those needs, and really look at improvement along the way to both grow and improve the business.
So does that start from sort of demographic information as well, or is it really just about perception and experience? I don't say just in terms of only about that, but I mean, is it limited to sort of the qualitative responses and the perception and the satisfaction of the patient, or does that also include demographic information?
Yeah, good question. It does include demographic information as well as any qualitative, but we take the information and we're able to identify how are you benchmarking against others? What does it look like in your area? So for instance, are you in an area that is much more competitive? And what does that look like for both your current patients and future patients? What do you need to do? Anything from the age, the language, the sex of a patient, right? What we know in the social sciences is that all of these components contribute to how people make choices. We help with making choices for your patients. What about based on each individual provider? How are they being ranked and rated? And then how can that be improved? And putting those scores, many put them on their website to translate the numbers into stars to make it easy for a consumer to choose you, to know who are the best ones that they want to go to.
That's interesting. I mean, I'm even thinking about before that, even just planning expansion or service offering. If you're a solo practitioner and you're looking to expand your practice or diversify your service lines to sort of protect your own financial well-being and health, really important to know the demographics of the community and the other providers in the community so that you know, well, maybe by offering a new service, a new specialty, and bringing on staff, not someone in your own specialty, but somebody in a diverse specialty will help you kind of reach more of the same market without having to find new patients, say whether you're a plastic surgeon or a gastroenterologist, whether finding more people to provide gastroenterology services on to determine if the population mix is right, to bring on maybe an ophthalmologist or somebody in another specialty that might be able to serve that same community without having to kind of cast a wider net. It just seems like it would be an important business intelligence information as well as patient experience information that helps you elevate quality.
Right. So how can you grow wallet share based on your current patient population and who you're able to bring in, both themselves as well as their friends or family? Because that's one of the areas that we find in healthcare, and particularly in this area, that you're able to grab greater market share and grow that. What's the propensity of someone to choose you based on what your current scores are, and then looking at some other type of procedure or treatment they might need that they or their children or their friends, and what's the best way to reach them? How do you target them with the right language? When's the best time of year to do that? And another piece is, as you are thinking about growing, we know through all of our data that when you're opening new practices, if you do certain activities prior to opening, you're able to reach someone and receive higher scores than if you just decide, let's go ahead and open. We see when you're opening new practices tend to start with a lower score and they evolve as people begin to know you. They get the second visit, the third visit. And what we look to do is, can we cut that time to excellence for the provider?
It's interesting because that sort of brings around two thoughts to me, just from a business and strategy standpoint, is that one, if you are, this serves not just an established facility that's looking to expand, but also maybe a newcomer who is looking to establish a facility in an area that they know needs the services. Maybe that changes the calculation of striking out and hanging up your own shingle to say, wait a second, there's already somebody with a great reputation and a great amount of confidence and high scores in the area. By partnering or adding myself onto that practice, I can, shorten that runway to excellence and more immediately access the patient population for that existing facility. It provides that diversification that we were talking about. But, at the same time, I think, for me, as we talk about the patient experience and sort of growing wallet share, but when you think about it in terms of strict healthcare, if you have established confidence and safety measures and an understanding within the community, and you're serving their needs and you're giving them a positive experience, then that increases, one, the access for a community, and two, when they need more care, they know that they have confidence and comfort there, and they can go to a provider that they're already familiar with and they already have touch points with, and then they can grow, from their perspective, sort of their healthcare needs, and sort of have one-stop shopping that they're comfortable and confident in, as opposed to, I think of, sort of maybe an aged population where they're kind of looking around for multiple specialties. If the trusted provider in the neighborhood that's providing safe care is slowly growing to reflect their needs, their access is growing with their needs, and their confidence in the safety level is also growing in lockstep with the needs as they evolve, right?
Exactly. And you used a few words which are really important, and particularly since COVID. One of the things is people look at their care differently. So primary is the quality and safety of care. And so they are looking, are you accredited, and are you holding yourself up to the highest standard? Because that's an expectation, right? So just coming in. And the second word used was confidence. So the concept of patient experience surveys used to be about happiness and satisfaction. And that's an easy way to talk about it. Oh, it's the satisfaction. The reality is it's about the confidence, and in two ways. One is the higher confidence that someone has in the care there for the provider and the team, then they actually will have greater confidence in their ability to care for themselves when they leave, and any work that they need to do, medication or treatment. And secondarily is then that confidence builds so that they aren't as fearful. They're not as worried for the next visit, or to call them and refer the provider to a friend. What we know now in the science is when you don't have that confidence and you're fearful, it actually changes you physiologically. So it's not even about what is the score you're going to get from a survey, but your patient is coming in. Imagine your patient coming in more relaxed. That means the brain is open to listen, to be able to know what's happening. They're not closed down. And when you're talking and discussing what will be happening with the treatment and what they need to do at home, they actually can take that in more. And so the goal in all of this is about confidence, in the confidence that patients have in the staff and the team. We are now seeing data that patients will change providers based on the service and care that the team is providing them. So you might be a provider that has the best outcomes in terms of your surgical skills, but if you can't add those other components, then patients are saying, we need to be cared for in a different way. And so the goal is to be able to reach that confidence level so that they are coming back the first time, the second time, and they have trust in the care team.
Yeah, I don't remember if when you and I were first talking about these topics, if I mentioned, 2 or 3 years ago, we commissioned anonymous studies into patient decision-making and patient experience. And the very first thing I thought was very counterintuitive to most physicians that I talk to who say, patients don't want to go to the hospital. It's where sick people are. It's scary. But the truth is, when we talk about patients in general, as opposed to the patients that we already have as an outpatient facility, our data that we commissioned the study, and we didn't do it. We had professional, real researchers who know what they're doing do it. It revealed that really the drop off from the willingness to seek care in the non-hospital setting was still significant. 12% more patients were willing to just forego care if they had to go to a non-hospital setting because they lacked confidence in that setting. Just conceptually, it didn't feel as complete to the patient. And, we dug into that and we got some great insights on how to reverse that. But just, in support of what you were saying, it's very clear that in the general patient population, elective care, patients still on the population level prefer the hospital. And even though we know the care model is just as good or better and cheaper to go to the outpatient model, the confidence still hasn't kept up with the changes in technology and care.
Exactly. And it's in creating that ease of use for patients to be able to really shift to that outpatient. The concept that it is safe, that people will take care of you, because the judgment actually goes a little higher, right? They're looking at it differently. There's just a different esteem when you're in a larger facility and watching and seeing so many clinicians. You want to mirror that through that confidence in being able to anticipate patient needs. So you're not making them reach out and find, what do I do for travel? How do I prepare myself? What are the things? So you want to show that you're on top of it. So you are sending a text message to say, at 2 p.m., remember not to eat after midnight. You are understanding how they're living and what their fears are so that you can make it smoother and increase their confidence in order to continue the growth in the outpatient.
That's a great point. I think that's one of the biggest things is that there's this trust in this large institution with a big hierarchy. And so you have to overcome that just kind of perception, right? Just large is kind of good in many people's perspective. So very interesting. So I think we've set the table really well and had a really good conversation. I didn't plan on, but just based on your opening, you led me down a really interesting road that I thought was really good, because I just think it's a good concept for especially smaller and mid-sized organizations to really think in this direction, because so often the busy day-to-day takes so much time, especially for a healthcare practitioner, because it's not just running a business, there's also providing the care, and that all takes a tremendous amount of attention and effort and calories to focus on, so you don't always get sort of the broader perspective. So I think we've set the table really well, but in order to really kind of get a little bit more into the meat of your service and the surveys to make sure that people really get a good appreciation for them, I'd first like to ask sort of how surveys are organized and what topics they cover so that people can really start to kind of wrap their head around the practicalities of it.
Absolutely. Now, when we are talking about the required ones, the regulatory, right, those are dictated in terms of here's what CMS is going to require you to do. And they want to frame it up, they do it in terms of making sure that you can manage communications with all the questions that go with that, that the preparation for the care that the site is managing, that the connection and the work with the staff is there, that the aftercare, right? So that's something that's really become incredibly important and has evolved since these OAS caps started in 2022. It's by getting this feedback to say, here are the things. Here's the important things about the facility and staff. So staff ensured that you're comfortable, that you're treated with courtesy and respect. The clerks and receptions were courteous. So there's these overall subjects of the faculties at the facility and staff, communication about procedure, discharge and recovery, and then your overall rating. And then within that, there are multiple questions. And this allows each area to then find out. So for instance, in discovery and recovery, there are different questions from, did you get information regarding a response to infection, all the way to, did you get the instructions regarding recovery? And the staff is able to get this feedback from the patients and see where are they high, where are they low. And then they look to say, how do we begin improving where we're getting lower scores? These are great indicators. And the teams can look at it by many different components, but you're able to get this immediate barometer that across that continuum of all those touch points, where do we need to improve?
Yeah, and so just two thoughts there. One is it's pretty comprehensive, even as the required elements go. But would I be correct in assuming that if someone is implementing the surveys that are required as part of a regulatory mandate for a Medicare-approved facility, that's sort of the core, but they could expand if they had sort of customizable or customized desires and needs. And if somebody's not a mandatory participant here because of Medicare participation, they could still define sort of the scope of their surveys to be somewhat different, whether they want to respect that same core of information or not. There's at least a little bit, there's some flexibility there in terms of understanding kind of what their data needs might be.
Exactly. Where it's regulatory, you need to be able to adhere to that, but then ask specific questions. I think changes have happened with both technology as well as CMS and participation. And what that has allowed us to do is to advance the way in which we're surveying. So you may not fit in that regulatory, but we have many who have it and they're still surveying. And no longer is it only this mail survey, but OAS CAPS was the first one to start with the web-based. And we have facilities doing is it web-based. They now can put QR codes and get immediate feedback. So if you are asking about waiting, it's not regulatory or it is, you can get immediate feedback about that or about something else that you want to get from your patient. So you don't necessarily have to wait until somebody leaves to find out, is there something you can do? So there's more options now. And I would say that what we've seen, and particularly those who may not be adherent to the regulatory, we're seeing that increase in them asking questions that are guided by really many of the regulatory to say, here's what patients need the most. And they're looking to say, all right, let's try that. Let's either do it as a web-based, send an email, a text, or do QR codes. How can we advance in either space so that you're meeting needs and exceeding needs of patients? And at this point, the other thing you're able to do is you're able to add to it is, can you go ahead and give us that rating and also a Google review, right? So you're able to ask that at the end when you're in this mode of giving great feedback, that how can you take that data and publish it out so others can see it?
It just seems so valuable for a facility. But the other point that when you were giving your initial answer that stood out to me is even just as you were covering the areas that you're surveying for, the regulatory surveys mandate, it layers really closely over accreditation as a as a statement of quality, as a standard, and as, kind of what the facilities need to adhere to from a safety standpoint, to where here's the sort of, it looks like a scaffolded approach where here is the regulatory requirement to provide safety. And furthermore, here is your patients, your population's perception of what you've done to provide that safety and how well you're communicating it. Because I've often argued and presented on sort of the ROI, the return on investment of patient safety. You're investing time, energy, and effort in providing the safest possible care, maybe not necessarily spoken, maybe implicitly, to build patient confidence, win patients over, and retain them. But are you succeeding? What's the ROI? And it seems like that these surveys provide a real opportunity to quantify and to drive that ROI as an extension of that regulatory compliance.
Exactly. And instead of making assumptions that we think these activities that we're doing and these interactions are yielding that for us, you're able to find out if they are. And if they're not, or even if they are, who is it with, right? Are there certain demographics? Are there certain races that, or is there a gender that is looking at you more harshly than another one? Looking at it from a zip code perspective, one of the things we found with one ASC is in certain zip codes that we're getting lower scores, and we found out from a competitive perspective that one of their competitors was marketing more. And so this can also help you geo-target or connect with populations that you are either looking to improve the experience or gain more market share.
So based on that, with the insights, based on your current patient experience, feedback, the collection of surveys, are trends emerging, or have they emerged over the years that have really solidified into almost concrete learnings? I mean, what are you seeing out there?
The surveys themselves have evolved because of the feedback we're getting. And the outpatient world is incredibly competitive, right? The most competitive is the individual provider. Then next is outpatient. And so any little improvement is actually difficult, lifting that up for improvement. And we see that in general, in the consumer world, patients who are female tend to be more discerning, right? Women have more mirror neurons than men, so they're taking more information, and they often are the chief medical officer in their home, making medical decisions, healthcare decisions. And so if it's like what Lowe's did years ago, when Lowe's decided and saw more women were coming in to shop there, that they changed their stores so that they would be wonderful for women and they gain that market share. Same with healthcare. If you are able to meet the needs of women, men actually also will increase. But you have to make sure that you're meeting the needs of the different groups. We see trends by month, right? So if you're looking to say, I want our top rated score to be 88, you're already at 87 and it's going to be 88 every month. Well, in this world, it's never the same every month. And what you can do with your data is you can do predictive analysis to find when will it be higher or lower. There's something that we know in terms of, even Google has it. They call, what's the Google misery index? And it's when people search the most for anxiety, stress, depression, and sadness. And it's 2 times a year when people search for that the most. It actually happens to be when our serotonin receptors recede. And so in knowing this data and information, when you see that your clients and your patients need more love, your staff need, I call it more love, because they can't make as much of an effort. So that's when you want to make sure that you're helping the most. So that if you see in March or April your scores start to go down, you want your staff to understand this, because the effort that they did in January is not yielding the same. And you don't want to look and say, wait a minute, we're not giving the same experience. You might be, but someone may not be at that place that they can actually give you the highest score. So you have to look and say, what needs to happen? What do we need to do? What does the undulation for your center look like throughout the year. And so that's a big one. I also found that I was in Saudi Arabia this past year helping do improvements in the outpatient world, and we found the same trends. And so it's to know that, anticipate it, and then through some predictive analysis, be able to say, this is what's going to happen, and let's look to see what we have to do about that. That's one of the large trends. We also see trends from a geography perspective. And so you might have multiple centers, and you might be in one state, you open in another state. You say, wow, we have the same protocols. We did the same marketing. We're doing the same pre-call and the readiness and equal of quality of our clinicians. And why are we not getting the same scores? And that's another thing we find is the propensity for people to give scores differs by the culture they live in. And so there are areas and states where you get higher scores compared to lower scores. And that's why it's important to understand that so that you can then manage to it.
It's interesting. I don't know that we necessarily associate healthcare with seasonality in the same way that, an accountant would. Obviously, tax time is busy time. But even then, I think even if the care itself isn't seasonal, the perception and the way the scores are perceived might certainly be seasonal. I mean, obviously, probably people are sicker in the fall and in the winter, and so maybe they're not feeling as well. But also, even if you're providing the same care month after month after month, I don't know, January and February in Chicago get pretty gloomy. Right. And so you're more likely to see everything with a slightly negative hue than you would in June and July. So it's interesting that I don't think people often, that's not the first thought when it comes to the mind of the patient experience from healthcare, because we're really thinking very clinically. Right. But the truth is, it's still a whole person. It's still a whole patient. And all that baggage from the outside, even just bad weather and heavy traffic, and I stepped in a big cold puddle on my way in, affects the way they see your care model and your staff.
You're absolutely right, Tom. And it's what's that tolerance level that people have to these barriers or these extra work they might have to do. So someone might not mind making the extra phone call, driving further, having difficulty parking one time a year, then another time a year, and seeing that and knowing that. And here on the screen, we have a map of the United States, and it's color-coded by the outcome of the question of recommend the facility in the OAS CAHPS surveys. And it's high to low. And if you look at your top states, that's Rhode Island, Louisiana, New Hampshire, Utah, Oklahoma, and Texas are giving higher scores. But your lower scoring states, North Dakota, and Montana, and Minnesota, you want to look and say, wait a minute, why is there a difference? What are we doing different here? And it could be a 10-point, 15-point difference. So you just want to understand where are you, both in your geographic area, in the state, in your community. You'll see differences by county. And so the more that you can understand your data, think about your patient experience similar to you're looking at your clinical experience. You're titrating what your treatment might be based on your patient in front of you, how they weigh, what they've had before, what's their tolerance for medication. It's the same thing to look at for your patient experience. And as you look at the percentages that typically you'll get a higher percentage of feedback, as we see here with females, where 58% response rate compared to 42% for males, yet it's yielding a top box. So 88% of the males said, yes, we're giving you the highest score, and 87.69 for women are not. That's a small difference there from a number, but not based on your response rate. That really can make it large for a facility.
So it's interesting. So from the state standpoint, you mentioned Rhode Island and Louisiana and New Hampshire, are the top scoring states. So if you're a provider, just to take this into the provider's world, because not to I don't want to talk down to any providers out there, because I think often they're doing a great job, but I also do think that in my experience, many providers are somewhat isolated, and they're really worried about their practice, and they're really focused on how they can make their practice the best that it can be. But I do think there's a great appetite out there for benchmarking data. And here's a perfect example: if only, and I say only, 85 or 83% of your patients would recommend your facility to someone else, and you're in Rhode Island, 83 might sound great, but compared to the average facility in Rhode Island, which looks like it's getting 89%, you're behind the eight ball. Whereas if you're scoring an 83% of your patients would recommend you, and you're in Minnesota or Michigan, you're ahead of the rest of the market. And it's the same 83%, but you're outperforming the norm, it sounds like. And similarly, if you're in a larger organization that's multi-state, knowing that this facility in Minnesota may not be worse than your facility in Rhode Island. It's just that the population doesn't react the same. It allows you maybe to give your staff some grace, and to give yourself some grace, and say, hold on a second, we're dealing with a different patient demographic here that has different recommendation rates. So I just think from a business intelligence standpoint, it's fascinating. And again, if you're a multi-state facility and you've got 89% recommendation rates across the board, across multiple states, then potentially you've got some lessons learned that you've been able to manage this across the board, even though states have a great degree of variance. I think that's really powerful stuff, to just kind of know the environment you're in.
Yeah, the power of this data to be able to help drive the precision in both what you are delivering to your current patients and build your future patients, I think really gets overlooked, because often this data really at a provider level gets to their identity. They commit every day to say, they have spent their lifetime working towards this to be the best, evidence-based. And when they see a score that they're not the best, or it might not be as high, it can be demoralizing. And if you go to their identity, the key is to understand the science of experience and what's behind it, so that they can work towards what needs to exist in order to get there. It isn't often just it's me, it's the provider. It's what's happening with the patient, what's happening in their world. How then can you compensate and understand that to make changes to the experience?
Well, and even, discussing what you said about, kind of women typically being the chief medical officer of their family, I'm reminded of sort of the, business school cases where it's really about the expectation gap, right? And my wife does very similar research for her employer. And interestingly, we find if you put some of the retail outlets next to each other that she works with, and you were to look at them objectively, you would see one that is in a far greater state of disrepair and, less, fewer items on the shelf and things like that. And yet their satisfaction scores are much higher than in super affluent areas right near their corporate headquarters or whatever. And it's quite interesting to me that, clearly the consumers in one area expect a heck of a lot more than the consumers in the other. The consumers in the other area just want to go in and get their product and get out. And so their satisfaction they're getting exactly what they expect. They're getting the product they want. Whereas here, maybe it looks like the learning I would take here is maybe female patients tend to have a higher expectation of what the patient experience looks like. And if I'm treating a primarily female patient population, or if I'm appealing to a female population, say mothers, for example, I might tailor my offering a little bit more to meet that expectation than if I'm treating primarily males. And you mentioned Saudi Arabia, and I was doing a similar project for Quad A here in last year in Zambia. And in Zambia, in one of the district hospitals, they actually have a completely separate hospital for men. And it's called the Men's Clinic. And partly the reason they do that is because they realized through data like this that they couldn't have the men waiting more than 15 minutes. Because if they waited longer than 15 minutes to have the men in a room with a doctor or nurse, the men would leave to go back to work in the field or wherever they worked. And so the men's clinic was designed to say, we finally got you in here to take care of yourself, because typically their patient population, is more likely to ignore the problem and to try to work through it. To say, we finally got you in here. We want to keep you and make sure we can take care of you. So we're going to make sure we're going to put you in this fast track to make sure that you're seen in 15 minutes. And they adapted to that information really quickly. And I just, this data about sort of the female likelihood to recommend versus male being off by half a point, but it's big on a population level, was pretty interesting to me.
Yeah, they brilliantly, in your example, understood the lived experience of the person. And that's really what it is about. And the science of experience, two things. One, that your wife, in that example, one is decision fatigue. So the more that you're making someone decide, so that having a choice of 3 is better than having a choice of 6, but also decision fatigue in terms of, what are you making your patients do? Are you only making them hit a button to say, yes, I'm coming in? Or are you making them do 3 or 4 things and call this one and have that test? So the reduction in touch points and what they can do actually increases the satisfaction. And the other part we would take from perhaps what your listeners, if they think about the sports world, Tiger Woods, would talk about when he golfs, he sees it, he envisions it, it's in his mind how he's going to address the ball, where it's going to go. He sees it ahead of time. We call that experiential blindness. And it's, if you provide information to your patients on the web in materials so they know what to expect, they understand what's going to happen, then you'll have higher scores. It's why you see the second visits and then the third visits after keep getting higher, because when you don't know what's happening, your brain stays in this sense making and more fear. So you want to reduce that by giving them the visuals, videos online, walk them through it, both saying it to them, but let them visually see it. And now they aren't as afraid, and they can actually be prepared in a way that they don't now have an incongruence between what they expected and what they received.
That's fascinating. So given that the patient is sort of learning to feel comfortable, right, at the same time that the provider is learning to meet that expectation, have these data that you've collected for facilities or across the board revealed any kind of priorities that patients have for improvements, either localized or generally across the board? Are they saying one thing is more important than another, or is it kind of all over the board depending?
Yeah, the first thing is they want that courtesy and respect, and they want that comfort. That is even higher than having the right information. So that gets to that human level. So it's really, what's that human experience? And can the teams connect with with the patients? And you look at who's giving the highest scores, it's when they feel respected, that they're spoken to. For the elderly population, if you ask a question and then you ask a second question, then they'll feel listened to. And so the first part, it really is about that communication and how you're making them feel. And then you start getting into, is the facility clean? As we have up here now, this is from Recommend the Facility. Over time, we're able to show what is most important from a hierarchy of priority down to the not as important. And so understanding information and your instructions, And then is the team helpful? So those are your top ones, but it's really first, how are you making them feel? And do they feel comfortable in what's happening? And then needs to be clean. Do they have the right information? As they're going through the treatment, are you checking in with them? Right? So they started off okay, but how is someone continuing to connect and keep tabs on them?
I think the revelation here, and it's not much of a revelation, but the way it quantifies and puts proof to it. So for anyone listening, we're speaking about this in hopefully clear enough terms to understand what we're talking about. But for anybody who's wants to see some of these slides, if you check out the Quad A YouTube page, we have the visuals to this podcast as well. And so you can see the slides that Joan's talking about visually, and you can get into more detail. But hopefully if you're just listening along, you're getting enough information. But as I look through this, so much is about comfort, respect, and understanding. And I thought you said it really well. When you don't know what to expect, your brain's sort of on high alert. You're in a fear mode. And so you're sort of even implicitly wondering what's next, what's the next shoe to drop. And as you go through this, it's very clear that this data is relatively stable over the last 4 or 5 years of data. And that's courtesy, comfort, cleanliness, I think, is super important. And it's probably the one thing that's a little bit more of an absolute and not kind of a touchy-feely piece, but things being easily understood, speaking to patients in the languages they can understand, not just language and sort of, English versus Spanish versus French, but also technical language and not over jargoning them and things like that. And just people being helpful. I mean, I sort of get struck that the older I grow, the more I sort of think back to the information, the advice that your grandmother or mother gave you on the first day of kindergarten really just dictates your life. And be nice to people and deal with it and kind of speak to people with respect. And I think that is like the takeaway that you can kind of always take. It's kindergarten advice, right?
Absolutely. And they will keep coming back.
So, I know we're getting up to time here, and I don't want to belabor these points, but this is just such valuable information. But I do want to ask, you mentioned the financial benefits and the incentives for the Medicare folks. So I wonder if just quickly in closing, you can summarize the financial benefits. And then for anybody who maybe is not aware that they're required to do this, if you're Medicare providing and you're still maybe not fully informed, what are the deadlines to implement all of this survey information so that they kind of know to get themselves ramped up in time and they don't face any penalties? If you can kind of summarize the two of those points.
Sure. The way CMS manages this is they hold back a certain percentage of what you should get paid. So 2% is held back in order for you to meet both the patient experience and quality and some safety scores. And if you meet that, then you'll be able to receive those monies, right? So you've already put out the time and the effort. And for January 25, where it is mandatory for those who are non-hospital based ASCs in any Medicare payments, the October 1 is the date that you need to make decisions on the survey, who is your vendor, how is the process happening, any extra questions, so that can get managed and that you can begin surveying for January in the mode you want based on your population. So that's coming up in 5 weeks. If that is not managed yet, it's something to make sure that you're on it now.
And just for clarification's sake, those are facilities that are participating as Part A. Is that correct? So that would not be just a private practice where the physician is billing Medicare under their NPI number. This is for participating facilities. And can you, just for clarification, do you know if the surveys and such are also required for rural health clinics or for the rehab agencies that might be participating and providing PT, OT, and speech services, or is it just ASCs at the moment?
It does include some PT as well and OT. And so we can go ahead and make available exactly the full criteria, and people can check in to see if do they fit within that. It is particularly if you are managing to specific Medicare populations.
Perfect. Okay, thank you. So I know we do have kind of run up on time, but I do really appreciate this conversation. It was extremely enlightening for me. I think as you can tell, I had a lot of follow-up questions because a lot of this was new information for me to this side of the patient experience. So I do want to thank you for your time. And for those of you listening, I want to thank you for joining us on this enlightening episode of Quad A Now podcast. We appreciate Joan taking the time to share her expertise with us. We hope that you found today's discussion as informative and inspiring as we did. If you have questions or would like to learn more about today's topic, be sure to check out the links in our show notes. Don't forget to subscribe to the Quad A Now podcast for more conversations with leading experts in the medical fields. Until next time, stay curious and keep exploring the advancements in patient care and safety. Thank you for listening, and we'll see you on the next episode.
That's a wrap on another enlightening episode of Quad A Now, a global accreditation podcast. Stay tuned for more captivating discussions with leaders who are shaping the landscape of quality and patient safety. Remember, patients first, always.